Assalamu alaikum. I would like to thank the organizers of this conference to give me an opportunity to talk about this very important subject which is quite close to my heart, and that is resident autonomy. Now, autonomy has its roots in Greek language and is a combination of two Greek words, autos and nomos, which means self and law, and autonomous meant having its own laws in Greek. Since the early 17th century, this word autonomy is being used in English language, and here in our context, autonomy means the capacity to take control of one's own learning. Now, this concept of graduated level of independence and responsibility is the basis of the initiative in medical education that we now know as competency based training. The residents define autonomy as a dynamic and progressive path to operative independence. The way in this incremental level of independence is granted must be thoughtful and deliberate, of course, to ensure patient safety and also appropriate supervision. During training, supervision is critical in ensuring the patient's safety, yet, adult learning theory highlights that learning occurs when trainees are challenged to work beyond their comfort levels. Now we have to strike a very fine balance between resident autonomy and patient outcomes. On one side, it's residents' education, satisfaction, and creating competent and autonomous practitioners, and on the other hand, is patient safety with excellent outcomes, value of care, patient satisfaction, and ethical considerations. Now, there are multiple factors which contribute to the erosion of resident autonomy and decreased operative experience, including different views of autonomy between supervisors and residents, and of course administrators and healthcare managers, then financial forces, then duty hours regulations, and diverse community healthcare needs. Like just in COVID pandemic, we have seen that elective lists were cancelled and only emergency and only malignant cases were being operated, and that has also resulted in decreased operative experience. Now, there are various theories which support this autonomy. The self-determination theory says that the adults would require to be competent, they need to be effective in dealing with their environment, they need to be in control of the course of their life, and they need to have a close, affectionate relationship with others. Now, this self-determination theory tells you that if these three basic needs are met, the person would be well-rounded person and would do well in their chosen profession. Then the expectancy theory of motivation tells us that the belief that increased effort will lead to better performance, and the belief that acceptable performance will grant rewards, and employees consider rewards as valuable. So the more effort you would put, the better would be the performance, and the better the performance, the more reward you get. So once the residents know that the more effort they put, they perform better on the operating table, improve their skills and show their skills, and they are rewarded with autonomy or entrusted professional activities. Then there is this cognitive apprenticeship framework where we start with modeling. The mentor demonstrates or walk through the initial steps of the process while revealing the tricks of the trade to their mentees. The mentees are then observed by the mentor with provision of guidance and feedback. The mentee is supported with a scaffolding throughout the task and gradual fading of such support. The mentee verbalizes the reflections after the procedure has taken place and then self-assesses their own performance, and then they try and explore the topic beyond what was shown by their mentor. Now, the three-phase process of decisions on takeover was basically built on this qualitative semi-structured interview with 43 expert surgical teachers from 21 institutions across 4 regions of the United States. They identified a three-phase process of the surgical teacher's decision on whether to trust the resident to operate, when to entrust them with their professional activity. Now, these 3 steps were monitoring performance and identifying the red flags, then assessing entrustability, and then granting autonomy. Now, the performance was monitored, and if there were no red flags or no triggers, they were moved on the next step. But if there were triggers, they examined the evidence, and on the basis of the evidence, if the evidence was such that they were not allowed to continue, the surgical teacher took over. If they were evidence was such that they were allowed to continue but with attending's reactive assistance, and then they were allowed to continue with attending with proactive directions. Now, depending on these, once they passed that step, then they were interested with autonomy and they were moved on to the next step of their training. Now, supervisors' responsibilities are very important when we talk about residents' autonomy. They have to utilize their best judgment when a trainee has demonstrated appropriate trustworthiness, level of awareness of his or her limitations, and I cannot stress enough that this is a very important thing, that the mentees, the trainees are aware of their limitations. Then adequate competence to be given the autonomy to perform a particular patient care task, provide constructive feedback that is specific enough to allow residents to understand how to improve their performance and to reflect on their teaching and its effectiveness. If a resident is not coming up to the mark, if they are not proving that they are improving, then we have to look back and reflect on our own teaching and its effectiveness, that maybe it is our supervision or lack of it which is resulting in residents not gaining enough operative skills, and to adopt new techniques that may improve our trainees' learning and retention of knowledge and skills. Now, trainees have responsibility. They have to be prepared when they come to the operating room. They must have the appropriate knowledge of the relevant anatomy. They must be familiar with the steps of the operation, and they should discuss the surgical plan with the attending prior to surgery. They have to develop an awareness of their limitations and a willingness to ask for help when they have reached the limit of their abilities or comfort level. They must ask for feedback and engage in reflection on both their personal knowledge and the performance and how it can be improved. They need to hold themselves accountable for entering the operating room as prepared as possible, and this should include review of the patient history. Now, how can we measure autonomy? The goal of any training program is to graduate competent surgeons who can themselves operate safely, independently. Now, this competence and objective evaluation must be appropriately documented. Now, we have various tools available at our hand like O-score, the Ottawa Surgical Competency Operating Room Evaluation, the Swiss scale, the Procedural Autonomy and Supervision System, and Testable Professional Activities of OLITAN, the Superb Safety Model, and the Resident Supervision Index. We'll talk about a few of them. The Swiss scale has attending responsibilities from show and tell to passive help and supervision only. Now, they have to set clear expectations, give constructive feedback, provide appropriate assistance, and reflect on effectiveness of their own teaching. Whereas a resident needs to be aware of limitations and ask for help, demonstrate intrinsic motivation, reflect on knowledge and application, and engage in simulation and deliberate practice. And they move from junior resident to a chief resident. A junior resident is expected to deliberate practice simulation. At mid-level, they are expected to demonstrate competence in straightforward cases, and at a senior level, they are expected to demonstrate competence and independence in more complex cases. Now, it can also be seen in the BITD model, or the briefing, intraoperative teaching and debriefing model, and it includes briefing, in which the learning objectives are set of that procedure, then intraoperative teaching, which is during the encounter, and then debriefing, which takes place after the task has been completed, and it includes reflection, rules to be made, reinforcement of things which have been done, and correction of the things which need to be improved. Then this PAS, the procedural autonomy and supervision system, can also be used, and it can be used on our mobile phones, and you can very easily have a group and on which you can monitor your residents' activity and on various attendees who have been supervising their training, and then they can fill in these forms and answers, and you can have a resident's resume, and you can identify how much autonomy that resident can be allotted to. So the topic addressed is, let's say, Swiss scale, and the question is, how much guidance did you provide for the majority of the critical portion of this procedure? And the answer chances are show and tell, active help, passive help, or supervision only. While during the intraoperative performance, the question is what was the resident's performance for the majority of the critical portion, and the answer choices include unprepared or critical deficiency, inexperience with the procedure, intermediate performance, practice ready performance, or exceptional performance. Or the topic may be case complexity. How complex was the case relative to similar procedures? And the answer choices include easiest 2 scales, average, and hardest for 3 scales. Then this the very famous O score, the Ottawa Surgical Competence Operating Room Evaluation Score, it incorporates different facets of tools such as the Swiss scale to determine the level of assistance provided by the faculty surgeon. It starts from the pre-procedure plan, includes case preparation, knowledge of specific procedural steps, technical performance, visuospatial skills, post-procedure plan, efficiency and fluent communication, and all of them can be identified and scored according to the performance of the resident. Then what are the outcomes, the clinical outcomes which are associated with autonomy? In literature, there is some evidence that operations in which residents are allowed to function independently are safe, and they do not result in higher rates of complication than those in which an attendee is present for the entire procedure. Though the literature does not have vast evidence, but there is some evidence. And one such study by Siam et al. Demonstrated that there was no difference in outcome for appendectomies performed by senior general surgeons and general surgery residents. And this study was from Israel. It was a retrospective study over 1600 appendectomies, with 500 of those performed alone by a general surgery resident. And they found out that the rate of complications, the OR time, and the surgical site infections were more in the operations done by the residents, whereas their mortality was less. Now, as we've already discussed, to train resident, it involves a very delicate balance between appropriate supervision and progressive autonomy to develop the skills and confidence necessary for independent practice. With this in mind, teaching attendants must balance ethical obligations to both their patients and their trainees. The question to consider when weighing the potential ethical dilemma regarding patient safety and resident autonomy is whether increasing resident autonomy impacts patient safety negatively, positively, or indifferently. The published data on this topic is inconclusive at this time. Now, how can we improve resident autonomy? In our setup, we can shift from show and tell, just scrubbing them up and showing them how to perform a procedure, to active help towards a paradigm of passive help where supervision alone. Then standardized evaluation forms to track operative autonomy, and to give them constructive feedback during that evaluation. Open communication between resident and supervisor, and implementation of a resident-run minor surgery clinic, which we have been running for the past 3 years now and has shown good results. And then we can also take help of cadaver or lab-based simulation techniques. I thank all of you for your precious time, and if there are any questions, I would be willing to